Welcome again, everybody. I thought this is still on the first session, and I thought, the key to success for a presbyopic refractive surgery and so forth is a proper patient selection. I run through some of the slides very, very quickly. The next 3 or 4 slides deals with quality of vision and quantity of vision, right? And we have to separate the two. I mean, you measure a Jaeger or a Snellen acuity, and you find he's got a 20/20 vision. But the 20/20 vision could be like this, or could be like this. Now, the patient with the blurred 20/20 vision is not satisfied. It's as clear as crystal. So the good candidate for presbyopic refractive surgery have one desire only, and that is to get rid of the glasses. What you guys have to do is always remember this. Under promise and over deliver. Then you will have a satisfied patient. We know this, and Sudi is going to get into this about the depth of focus or depth of field, and he's going into it in more detail, so I will not divulge in that. Now, why is it that a patient of age 60 still can have some functional near vision? It's due to that the pupil gets smaller and the spherical aberration, which is increased. That is entirely due to the changes of the crystalline lens. Now, so the crucial question is, what should the refraction be for achieving optimal visual functionality? Now, we've heard some years ago about we're going to do supervision in LASIK. It's perfect, 2015 or even better. But we now have to reconsider to move away a little bit from supervision, because it's very, very clear that supervision is not the ultimate correction, not in daily life, because we are losing so much in mid-distance and near for this age group over age 45. The supervision eye will have such a small depth of focus that even at mid-distance, say 1 meter, 2 meters, there have to be an accommodative response to be able to see it fairly clearly. We have to look out for the patient who have a history of excessive complaints regarding their glasses and contacts, drive at night as a profession, or those that are even happy to wear glasses. Never ever try to persuade these patients to go into some form of refractive surgery. Those patients that have unrealistic expectations, stop and behold. And problems with nighttime glare have to be accepted and have a pre-existing significant ocular surface disease, that is to say, dry eyes. I will come back to that a little bit later, but there is later on a whole session about this. Our patients need to be able to adapt to glare and halos. And these glare and halos problems, this photopsia, is even appearing in normal IOLs, in monofocal IOLs. Patients must be able to adapt to astigmatism above a half. We will hear later on about where is the borderline. I say, if you have 0.75 diopter, you gotta correct it, because you will, if you don't, you will have such a poor visual quality that the patient will not be satisfied. You've heard this over and over again. Oh, doc, I don't think this quite worked. You have to give it some time and explain this to the patient very carefully, that this adaptation time you can't expect it next day. It might take a month, 6 weeks, or 8 weeks. This is one of the key things, and Sudi mentioned it. How about the ocular surface? One of the key factors for success, because the majority of your patients will, more or less, all of them have dry eye when they come to you, if above the age of 60. Even lower, because some of these people are very active with their computers, they are computer workers, and so forth. They have an instable tear film. Now, we have devised through ECCG a very simple method for you guys to find out if this is what this tear film looks like. And we will talk about that later on. So how do we see? Well, it's complex. It goes from the eye into the brain with a lot of information that's gathered in the visual cortex. Through adaptation, neuroadaptation can take from 2 months or even 1 month up to 6 months before the patient has adopted. And it's never too late to adopt to this. However, you need a little bit more chat time with these patients. We need also to understand the word neurogenesis. It's a learning and memory. And there are so many influences in the neurogenesis that goes to the hippocampal region of the brain. And it's responsible for consolidation of memory, emotion, navigation, and of importance to ophthalmologists, spatial orientation. So you have neuroadaptation and you have neurogenesis to take into account. We all know changes in life. The human being is like, I don't want any changes. I am happy as it is. Now suddenly, we are changing their aspect of vision to something that they never experienced before. And this, you also have to be able to explain to them in a proper way. So, there are challenges for us when we select a patient. They have to be taken into account spherical aberrations. Should we eliminate them or should we not eliminate them, and so forth. And you just have to explain it to them, because it's not good enough to say, give it some time. Then they don't trust you anymore. It's a yin and yang thing, right? The good and the bad. And the ugly. No, doesn't work. You know, it's psychological as well. If it doesn't work, then the patient really doesn't want it to work. If it works, it's perfect. If it doesn't work, it leads to discomfort. If it works, you are a god. Very few want to see worse in life, of course. So natural vision is related to a great degree to the environment in which we are living and working. I listed some of the environmental parameters here. As you can see now, and you look around in this room, everybody's playing with this, looking at this. They need to see it. What you also have to take into account, which is not listed here, what do they work with? Now, you take a lorry driver. He is sitting high up. So his gaze of vision is a little bit down. You take the bus driver. Our bus driver yesterday, he was sitting high up. His gaze is directed that way. Now, if you have the neoplan bus, where the driver is almost sitting on the road, his gaze is directed upwards. If you take the aeroplane pilot, licensed on the Boeing, his gaze is mainly up, a little bit down, because the instrumentation of the aeroplane. The Airbus licensed, he's got his computer ahead of him, so his gaze is going down a bit, more than up. These are some of the things that you guys have to take into account when you choose the patient and the method. So, functional vision, and it's best to customize the best overall solution for each patient. So the take-home messages I have here is the following. Considerations for choosing a refractive surgical procedure include patient preferences and patient age. Guidelines should never be binding law. Retain your ability to think a little bit wider. And patients must be maybe forthcoming about their expectations and demands when they are not in front of the doctor. They will tell your nurse or your assistant, oh, this is not good. And when they come to you in your sitting there in your white coat, if you wear one, they're stum. They don't complain. Phrase your explanation so that they understand it. Don't use medical terms. No, but your patient is not medically educated. Use simple terms to explain what can be achievable. And reinforce the potential limitations of all procedural designs. Your structure, your approach to the patient, and, have 2 or 3 different procedures as your premium offering. And you have to focus on 2 elements, visual quality and visual performance. Before I finish, Suryo mentioned Presby LASIK. I was done 2003 at Alio as an experiment, and it still works. Thank you.